presenter today, Terry Shepard.
Thank you, Sean. My name is Terry Shepard, and I am a pharmacokinetics assessor at the UK regulatory agency. I've been involved in vitro in vivo correlation for over 20 years. First as the head of biopharmaceutics at a controlled drug delivery company in Switzerland, and most recently at the UK regulatory agency, where I've been involved in drafting the revisions of the modified release guidelines that were released last year, and also involved in assessing a number of in vitro in vivo correlations for modified release formulations. And now I will hand over to my co-presenter to introduce herself.
Sure, thank you, Terry. I am Venkateswari Muthikrishnan, but I have a short name, Ishwari. I joined Certara in April 2012. Currently, I am responsible for training pre-sales support in South Asia Pacific and Middle East on Phoenix products, Phoenix WinOnline, IVIVC toolkit, Connect, and NLME. Prior to joining Certara, I worked in both US and Indian companies, mostly in the areas of DMPK and PKPD modeling. Thank you. Back to you, Terry.
Thank you, Iswari. So our agenda for today is, firstly, I'm going to give you some insights into the European regulatory view around in vitro in vivo correlation, and particularly to illustrate some of the key points that we look for through an example. And then I will hand over to Iswari, who will give some background information and also walk you through an example with the IVIVC toolbox. So to start, of course, companies are very interested to develop in vitro in vivo correlations for modified release dosage forms. And the reason that this makes sense for companies is because it takes a tool that is fast and is relatively inexpensive and employs it as a surrogate for a bioequivalence study, which takes a lot of time and costs a lot of money. And so it makes economic but also development time sense for companies. But we in regulatory agencies are also very interested to encourage companies to develop in vitro in vivo correlations for their modified release products. And the reason that we're interested in this is because it's something that anchors the efficacy and safety of the product, and it provides reassurance to us that a product that has a positive benefit-risk balance is maintained throughout the life of the product. And I'll illustrate this through the next example I'll show you. So I have a number of examples like these, but this one is typical, and so I'll just walk you through it. If you look at the bottom left-hand corner, you see it says MA, so that's marketing authorization. So in 2004, this modified release product was approved, and then you'll see that there are 54 steps along the way up to the year 2011. Each one of those steps illustrates some sort of change in the product or the information around the product. So in that time from 2004 to 2011, there were a total of 54 variations to the product, averaging 9 per year. And of those 54 variations, there were 30 pharmaceutical variations. And you can see the listing on the right-hand side of the different types of variations. So the manufacturer, the release site, the batch size, but also dissolution methodology and specification. And so you can see that for every product, every modified release product, but every product in general, that we need some sort of tool that helps us to anchor the efficacy and safety and really make certain that that applies throughout the life of the product. I will come back to that. So I will illustrate that with this example. So this is variation number 17 that came in 2007. And the purpose of the variation was to update the dissolution test method in line with the USP monograph and to change the specification time points and the limits of that. The supporting evidence which was submitted by the applicant included a quality overall summary, batch data, stability data, and very importantly to our discussion today, an in vitro in vivo correlation, level A. And I'll show you how this was done. So if you look at the panel on the left-hand side, you see a dissolution versus time plot, and in the middle you'll see a pink line, and that pink line represents the dissolution of the target or a pivotal batch that was used in the development of the product. And essentially this is a batch for which we have clinical data, and we're pinning our understanding of the quality, efficacy and safety of the product on that particular batch. And then you'll see that there's a lower and an upper line, and the points on those lines represent the proposed lower dissolution limits and upper dissolution limits. And so the way that this specification was justified by the applicant was to use these in vitro data and the Level A IVIVC, which you see in the middle plot, which gives the relationship between absorption and dissolution. And with the in vitro dissolution and the in vitro in vivo correlation, then they predict the concentration time profile that you would expect from the a formulation that released according to the upper dissolution specification, the target release profile and the lower limit. And then using those predicted concentration time profiles, then the applicant calculated the Cmax and AUC values for each one of those curves, and then did a ratio of the various values. And those are shown below here. So firstly, the upper limit to the lower limit, the upper limit to the target, and then the lower limit to the target. And so what you see below that then are the Cmax and AUC ratios for each one of those comparisons. So the assessor who looked at this evaluated these data, and the conclusions were all batches within the specification were expected to be bioequivalent to each other, and also that the proposed limits were considered to be appropriately supported. And most importantly, and this is what assessors will always look at, that the proposed change will not have a detrimental effect on the quality, safety, or efficacy of the product. So that's the example, and there are 3 points that I want to pull out of here, and the 3 points are listed here. Firstly, anchor to clinical batches. Second, relationship to bioequivalence limits, and then I want to talk about interpolation versus extrapolation with another example. So this anchoring to the clinical batches, the important point there is to keep track of the in vitro dissolution data that is associated with any batches that are used in clinical testing, and to be very clear about the data that correspond to particular pivotal batches, and to present those in any applications for which you're using an in vitro in vivo correlation. So for example, here for specification setting, but also for biowaiver requests, that you present all the data for which you have clinical, all the in vitro dissolution data for which you have clinical data, and that you're very clear as to where you're anchoring your, particularly the efficacy and safety. So that's the first point. The second point is related to bioequivalence limits. Now, normally in a bioequivalence study, you have at least 12 subjects. You may have more subjects than that, depending on the variability of the product, and you would do a ratio of your Cmax, geometric mean Cmax, and AUC with a 90% confidence interval. And if you look at the top profile here, this is illustrating a 90% confidence interval, and you would accept that it is bioequivalent if it's in this region of 80 to 125. Now, when we do when we use in vitro and vivo correlation based on mean data, in this case we only have a point estimate. We don't have a confidence interval, and so the way that we anchor it to the bioequivalence limits is to say, as long as that predicted point estimate is between 90 and 111, so essentially plus minus 10%, then we would expect that a confidence interval, if you were to do a bioequivalence study, would be within those limits. So that's how we anchor in a pragmatic way to the bioequivalence limits. The third point I will illustrate through a second example. So what you see here on the left-hand side is percent released in vitro versus time. And these are all in vitro, in vivo correlation study batches. So these were all studied within the same clinical study. And we have a slow, a medium, and a fast batch. And in this example, the applicant submitted a request to extend the dissolution limit. So you can see here the two pink curves with the observed data on there are the proposed new dissolution limits. And the difficulty with this is because we are able to prove that the in vitro in vivo correlation is predictable and is reliable within the dissolution limits that were used in the IVIVC study, but not outside of that. And so the lower dissolution limit then we cannot base on the in vitro in vivo correlation that was developed on faster batches. And therefore, there is some recommendation in the guidance related to this. So firstly, to keep in mind that it's only allowed when you have a validated IVIVC, that you can only use it to make predictions within that interval, so interpolation, and you can't extrapolate outside of the IVIVC limits. And the implication of this is for the choice of formulations that you use initially in your IVIVC study, that you want to use the widest possible range of dissolution behavior, keeping in mind that you may want to change your formulation later. Or change the specifications later, which we often see. But when you do this, that you need to balance the need to keep the release mechanism the same. So you don't want to change your release so that it's so that a different mechanism is coming into play. And the other thing that you can consider is to extend the IVIVC range in case it was not, in case you hadn't used a wide enough a range initially. You could consider doing another study where you extend that range, and if you do that, then you would need to think about including an immediate release or some other reference formulation in that study for deconvolution to allow you to do that with reasonable prediction error. So those are the key messages for IVIVC from the regulatory point of view is the best evidence of the discriminatory power of your dissolution tests. These three key points I've mentioned, these are all covered in two guidance documents that were released last year, and you'll notice on the slides that I skipped through earlier, that I've listed on there the two documents, but I've also listed where you'll find information in each one of those documents. So it's worthwhile for you to go back and have a look at that after the webinar. So I'll leave that to you to do. These concepts are also underpinned in ICH Q8 and Q10. But if you have a need for any product-specific advice, I just wanted to let you know that you're welcome to come to any of the national national agencies within Europe, so the MHRA or any of the other European countries, or you can also apply for European scientific advice. So if you're interested in any of those procedures, just have a look on our website or the EMA website, and we would be happy to provide assistance to you in this regard. And now it's my great pleasure to hand over to my co-presenter, Eswari.
Thank you, Terry, for an excellent presentation on the role of IVIVC model in product lifecycle management with MR formulations as an example. Now I am going to present a case study on the development validation of an IVIVC model, and then we will also look at a PK profile, how it can be generated for in vitro dissolution data when you have a manufacturing site change, how it is compared to the biobatch. So we will look at that using the IVIVC toolkit in Phoenix, Finland. So let's briefly touch what is an IVIVC. An IVIVC is a mathematical relationship that is satisfactorily predictive of some key pharmacokinetic parameters such as Cmax and AUC from using in vitro dissolution data. What are the goals of IVIVC exercise today? First of all, we wanted to determine whether an IVIVC is likely to succeed or fail. Then we would like to understand minimum data requirements for us to develop an IVIVC model using internal formulations or internal validation. Now, I will show you these steps in 5 simple steps in the IVIVC wizard. First, we will start exploring the data. So we plot the data fraction dissolved versus time. Also, we look at the plasma concentration type profiles, both at individual level. Also, we will generate mean profiles and then compare both these and then rank order them. Next, we will take in vitro dissolution data and model the dissolution profiles to one of the built-in models available. So we will start with in vivo data, estimate UAR, and finish complete deconvolution. Using fraction dissolved and then fraction absorbed, we construct IVIVC model, use that for predicting PK. So get into the details. In the in vitro analysis, we need to partition the formulations. So we need to assign what are the internal formulations, especially when you also have an external validation data set, you can assign that. And then you can define the models. And in vivo analysis, you need to select what is the reference formulation that you would like to use it for estimating the UAR. UAR is nothing but unit impulse response. That is a system disposition function that characterizes a API. So the most important thing in this is using common names, formulation names, same both in vitro data and in vivo data. Most often these data sets come from 2 different teams. So once you have generated those, and then you will look at the correlation plots and then assess whether you need to account for the scaling and the shifting parameters. So we will look at that in a minute in detail. And then once we have validated the model, we will try to predict PK for a new formulation. So I cannot hear Andre. I see some question. Can everybody hear me? I hope so.
Yes, we can hear you.
Okay, thank you. Sorry for the inconvenience. Let us look at what are the minimum data set requirements for us to go through IVIVC model development. So we need to have minimum of 2 internal formulations that are recommended, and no external formulations are recommended if you are only looking at simple validation using internal formulations. However, if you have a narrow therapeutic index drug, or if the validation is inconclusive, then you may have to consider external validation. In the in vivo tab, we need to have a reference data set, either IV bolus data, IR data, or oral solution. And you also have target formulation if you are looking at a therapeutic equivalence. So in the correlation model, we already know that we need to define internal and external. And finally, in the prediction, we need to have at least one test formulation in vitro dissolution data, or a target formulation, any formulation that you would like to compare your new test formulation with a known formulation where you already have in vivo data. So it is always recommended to use the same dissolution model that you have used in the IVIVC model development for this new test formulation also. So this is an example where you start with plotting fraction dissolved versus time, and then you look at the rank order. Here you see CR01 is the formulation that is fastest releasing, CR04 is the slowest, and you have CR02 and O3 formulations that are in the middle. So when you look at the individual subject plasma concentration profiles, you have to watch closely whether the same rank order, meaning CR04 is the slowest releasing one, in fact is showing slowest in vivo dissolution, and then CR01 is showing fastest one, and you have this IR as a reference in this. So let's also look at mean profiles for both fraction dissolved and then mean plasma concentrations. In this scenario also, as you see here, clear rank order was maintained between both in vitro and in vivo data. This suggests that an IVIVC model development is feasible. Moving on to in vitro modeling, we need to map what are internal and external formulations, and then you could select one of the built-in models available, viable, Hill and double viable, and Makhaid-Banachar. So I'm going to show you in a minute the shape of the curves. You could ideally start with one most likely model, and however, we do not have any automated model selection in IVIVC toolkit. So you might have to go one by one, and then finally, using a diagnostic criterion, you can select the best model. So as you see it here, these are the 4 built-in models that are commonly used in vitro dissolution model. So you could see there are simpler models, and then as you get into that biphasic double viable model, you would have multiple parameters. So you have to make sure that you have enough data to support this model fitting. Next, when we come to in vivo data, so you have to make sure you map appropriately, and then always start by subject, because you wanted to estimate individual subject UAR and then get fraction absorbed for individual subject. So make sure we map the subjects to the sort and specify what is our reference. So also specify the dosing route. If you are using IR as your reference, make sure it is oral or in oral route. If you are using IV, then you could select IV route. So now, when we come to UAR, so UAR usually is described in a Pauli exponential disposition function. So now for IR reference, there is also a component that describes the absorption process. So we need to strip the absorption constant from that. So you need to make sure we do that. I will show you that in the demo. You can use either AKT's criterion or SSR criterion for selection of the best model. This one is automated in IVIVC toolkit. You could select up to 3 compartments, meaning 3 exponents, and it will give you the best model based on one of these diagnostic criterion. Once you have UAR, you would be able to estimate deconvolution. So let's spend a little time on UAR. So when you give a simple scenario, IV bolus situation, the dose is given, the input is in one in one shot. So and then this is the output, which is a plasma concentration time profile, and then how you would describe the system disposition function is UAR. So usually AA and alpha I are the components depending on how many compartments you have. For example, in a simple scenario, A1 and alpha 1 are the exponents for one compartment model. So now, when you have an extravascular scenario, in our case, we have modified release formulation, and we already know UAR from the reference product. We can easily estimate fraction absorbed and then input rate. That is what we are going to use. So when you look at this extravascular, it's nothing but a culmination of absorption component and then distribution and elimination. Now, estimation of UAR from IR as a reference. So actually, there is an excellent section available in one of the guidance documents issued by EMEA. It is section 2.1 in the clinical PK document about how you select the reference formulation for your study. So it depends on the characteristics of the API, also the kind of product you are trying to develop. So while IV bolus or infusion scenario is desirable because it will avoid flip-flop questions with extravascular, especially in the case of modified release or slow release formulations. However, it is very hard to get IV data. So you may have to use innovator product. Sometimes oral solution is the next best option, but we need to watch out whether whether the API is getting precipitated out in the gut. So considering all this, so IV reference data is useful only for highly permeable drugs, while immediate release formulation is useful for the drugs which have faster dissolution than the absorption. And most of the times when you try to develop modified release formulations, that is the scenario. That is the kind of drugs that we would try to develop modified release formulations. So the drugs with limitations on the solubility and then permeability, oral solution is the best. Now there are more sophisticated software programs available that incorporate PBPK modeling also. But in our scenario, so if we select IR formulation, and then we can also sometimes have access to the innovator data, you could easily take the data and use it for the pilot study, if not for the pivotal study. Pivotal study, it is always recommended to have reference data within the study. Moving on to the correlation analysis. Now we have fraction dissolved and then fraction absorbed. You would like to look at the exploratory plots of fraction absorbed versus fraction dissolved, or LAV plot, TVO versus TVitro. This is the most important plots. So these plots will let us know whether we need to apply or account for time scale differences in time for dissolution and then in vivo dissolution time. So if they are different considerably, we may have to account for T scale. But if you observe any lag time, you have to account for the T shift in the model. And then app scale accounts for the differences in the absorption. And the app space is very important, especially when you have a hormonal product and then you also have an endogenous hormone present. So you may want to account for the app space. So once we have scaling parameters for both time and then shifting parameter for the absorption, you could select one of the built-in models, or you could built-in equation, you can write your own equation or develop a custom model. That is also available in IVIVC toolkit. So one of the things is most of the models are, while they are linear, but you could also write your own models in a nonlinear fashion. So let's spend some more time on this data. So this is a case study where we have a regression line. The red line is a regression line for the fraction absorbed versus fraction dissolved. So if you look at it, so if the regression line is passing through the 0, that means we do not have to account for app space. Otherwise, you may see the intercept on y-axis. And then you also have to pay more attention whether the time points in the end, are they close to 1, are they deviating from the 1. Then in case if they are deviating, so you may have to account for the app scale. So now if you look at the Levy plot, TVO versus TVitro, if you look at the regression line and then line of unity, which are overlapping each other, that means, so you don't have to account for the t-scale. So then t-shift, if you see any intercept on the x-axis, that's suggesting that there could be a lag time, you need to account for the t-shift. Now, these are some of the built-in models available in the IVIVC toolkit. The simplest model is, as we can imagine, we would like to have fraction absorbed is equivalent to fraction dissolved, but very rarely it happens. That is actually equal to line of unity. But the most often used models are fraction absorbed is equal to accounting for the AB scale, and then fraction dissolved accounting for the T scale. And in the model 2, we do have the T shift, which is accounting for the lag time. And then in the next model, we do have AB space, which is accounting for the endogenous concentration. So now once we have selected these models, so then you can validate these models and estimate prediction error. So the prediction error for average for all the internal formulations should be less than 10%. So one of the formulations can be 15%. So the absolute errors are used in these, and if any of the percentage prediction error greater than 15% and less than 20%, that means it is inconclusive. We may have to go for additional data sets and then use them as external validation. So next, we are going to take the data that is validated IVIVC model, and then in this case, I'm going to show you an example. We have developed a test formulation in a new manufacturing site, and then we already have a formulation that is, we have biodata, that is CRO3, and we wanted to see whether this new test formulation has very similar profile to the marketed product. So that we are going to look into detail in our IVIVC demo. So moving on to our demo now. So I have already a project that has been run since we cannot run the model during the webinar, but I would like to focus your attention to this data folder. We have 3 data sets. The first data set is IVIVC dissolution, where you see the formulation information, the time, and then we have data up to 4 hours. For each of the formulation, we have CRO1, CRO2, CRO3, and CRO4. And then we have fraction dissolved. And most often, we do get the dissolution data in percentage, but you can easily convert using Phoenix Winnow-Linn or Data Wizard into fraction dissolved. So the next important data set is IVIVC Vivo. So in this case, we do have time scale, and then but we collected data up to 72 hours. And then we have data for individual subject for each of the formulations, as you see it here. Okay, so now IVIVC new formulation. So we do have, as you see it here, for the new formulation, we only have dissolution data here. Okay, so this we would use this dissolution data to predict PK profile. Now these are the minimum requirements, and then these data sets have to come in as a separate worksheets. You could have as a multiple tabs in the same Excel file, but when you pull it into Winnow-Linn, so they will be a separate worksheet. Now, first of all, what we are going to do is we will start with our dissolution data, and then right-click, send it to plotting and XY plot, and then as you see it here, I have fraction dissolved versus fraction versus time, and then time is mapped to X, formulation is mapped to group, and fraction dissolved is Y. So in this, as you see it here, I have plotted all the formulations. I have 4 formulations, so CRO4 is the slowest, and then CRO1 is the fastest. Now, I also would like to plot in the similar way individual subjects. The only difference here is I make sure that each subject data is assigned to the page start and lattice conditions. So now we look at these results for each of these subjects. So the rank order still matches. CRO4 is showing the slowest profile, and CRO1 is showing the fastest profile. Now I have calculated mean using the descriptive statistics, plotted them. let's look at it. So we still were able to maintain the same rank order. So this is the good first step. So if we match the rank order of in vitro and in vivo, definitely we will be able to develop, proceed for IVIVC model development. Now I will start with the in vitro dissolution. Right click, send to IVIVC and IVIVC. So once I send the to IVIVC object, so you see it here in the setup, I have different panels. So in vitro data, where you map the in vitro data here, as you see it here, IVIVC dissolution. In vivo data, IVIVC vivo subject, and then prediction data, IVIVC new formulation. So this is where you go ahead and select source and then bring in this worksheet inside. So in vitro data panel, so the time is mapped and the fraction dissolved is mapped to dissolution, and then formulation is mapped. Now, the next step is we need to define what are our internal formulations, what are our external formulations. So we have 3 formulations, CRO1, CRO4. It is always recommended to use the extremes in your model development, and I assigned CRO2 as an external. So in vitro estimates, you have an option either to fix this estimate, especially for fraction infinity, to fix it as 1 or let the program estimate. And as we see it here from the data, we already know there is no T lag and then intercept. So we fixed those parameters and we assigned the values to 0. Now when we come to the lower panel, so in fact, you see in the status panel everything green. However, when you start brand new, you will see only red. As you move along, they will turn yellow. If you have data, once you complete the running the object, then you would see the green. So that means the results are available. So once we have done that, so I have selected viable model, the most commonly used model. For this data, the viable model works better. So then you click on the fit dissolution data. So that will fit in vitro dissolution data to the selected model. Here it is viable model. Now for the next step is let's go ahead and then view our results. So if I click on this view button, so I will be able to see the results for this, and then the CV% for each of these formulations. The model is very low, suggesting the fit is good. We could also look at, predicted versus observed, and for each of the formulations. And as you see it here, the viable model is able to describe all these formulations very well. Now let's move on to our in vivo. So in vivo, here you have an option to specify maximum number of year exponents, which is similar to 1 compartment, 3 in this case, I selected up to 3. Very often, if you go to the higher order, it's always challenging to develop IVIVC. So I have set maximum number of compartments up to 3, and then model selection criteria, we have 2 of them. Ekakis criterion are weighed SSR, and then I have selected Ekakis, and then no weighing was used, but if you would like to use it, especially when your data is of several magnitude differences, then you would like to apply one of those weighing factors, and you have to define what is your reference formulation. So in our case, we have selected IR formulation as our reference product, and the reference data, since immediate release formulation is extravascular, actually it is oral product, and then I have selected. Now I have also entered dosing units. So as you see here, when you go back to your setup for in vivo data, once you have mapped it, subject should be always make sure you sort that. And then time is mapped to independent, formulation is mapped to in vivo formulation, CP is mapped to values. And I also would like to point out here, so you need to fulfill the information about in vivo dosing, then only you will be able to generate UAR and followed by deconvolve. So basically you need to map this in vivo data, also provide the dosing information corresponds to that in vivo data. So once we have done that, so you click on the generate UAR button, then you would be able to see the results for the UAR. as you see it here, okay, so we can see it for individual subjects. So you see the Ka, A1 and alpha 1. So even though you have selected 3 exponents, it was able to select only one compartment because that was determined to be the best model. So you get individual subject UAR. You could also look at each subject's how the data was fit. Seems to be pretty good. Now the next step is, since we have UAR, we have plasma concentration time data, so we will do deconvolve. So you can deconvolve the data, and then let's look at the results. What do we get following deconvolution? So you get also average, but first of all, so for each individual subject, you would get input rate, you would get cumulative amount, finally fraction input. This is same as fraction absorbed. So you could also get have this fraction absorbed average, which is used in the IVIVC model. Now I would like you to pay attention to this in vivo data options. Generate mean profiles, do not generate mean profiles. This option actually in fact linked to how you wanted to estimate Cmax and AUC for your target product. So that we will look into it later. So once we have both fraction absorbed and fraction dissolved, so then move on to correlation. As you see it here, so we have different model we excluded, and then before we select any particular model, I think it's a good idea to look at these plots, T vivo versus T vitro, and fraction absorbed versus fraction dissolved. So I would just simply go to my filter and then type in Levy. So I would be able to see these plots. So this plot is fraction absorbed versus fraction dissolved. So you see this, what happened is after some time and then it reached 100% absorbed. So this solid line is a line of unity, and then this one is your regression line is definitely deviated. So now you go back and look at your Levy plot, which is T vivo versus T vitro. Again, your regression line deviated from your line of unity, and in fact, it is still going through the 0, 0. So we don't have to account for the intercept. However, we need to account for the scale differences. That means our model should include T-scale. While it doesn't seem that we don't, we have to account for upscale because it's almost all the data is reaching around 1. However, in our models, we have this model where upscale is already included. So, so we select this model, fraction absorbed is upscale and dissolved multiplied by T-scale. So we selected this model and click on build correlation. And then you go back and look at your results. So these are the parameters came from the correlation model. Upscale, as we see it here, it's very close to 1. That means it's not having any influence. However, T-scale has a major impact. The estimate is 0.23. And then you should also pay attention to the CV% to make sure that the parameters are estimated precisely. And next, you could look at this plot, the correlation overlay plot, where you see for all the formulations, so the fraction observed versus fraction dissolved. And this is the model that we are going to use it for further predicting PK. Now, before that, we need to do one more step, that is validating that model we have. So we are going to validate the correlation. For that, we need to make sure we specify AUC as like AUC last we are going to use, and then calculation method, linear up and log down. You could use one of those other methods also. And averaging is geomean. So once you select these and then click on validate correlation and then execute it, then you would be able to see the results for our IVIVC model validation. So as we already know that average for the internal validation, the percent prediction error should be less than 10. Here we have less than 10. So any of these internal should be less than 15. At least one is allowed less than 15%. So as you see it here, they are all pretty good. They all have less than 10% prediction error. So now we have a validated prediction model. As I was suggesting that earlier, so CRO3 we decided to have as our reference product, or I would not say reference, as our target. As you see it here, and then following the manufacturing site change, we have a new test formulation. So we plotted the new test formulation data with all the profiles that were used in IVIVC. Now I would like to know the Cmax and then AUC predicting using this IVIVC model, and then I would want to compare CRO3 with the predicted PK. So let's move on to our IVIVC back. So go to your prediction. I selected CRO3 as our target, and so as I already showed you in the setup, you have to make sure you map the new formulation data here, and also you have to give what is the dose of the new formulation. And then once you have done that, then you will be able to fit dissolution data, and then you can look at the dissolution model, how it is fitting for the new in vitro dissolution data. As you see it here, so this the data is fitting pretty good for this also. And now the next step is I wanted to compare the new formulation with reference to CRO3. So when I click on predict PK, it would estimate the Cmax and AUC last for CRO3. Also, it would estimate using the IVIVC model, and then in vitro dissolution data, it would estimate the plasma concentrations, and then do non-compartmental analysis, get Cmax and AUC. So once you have Cmax and AUC, let's look at the results. So you compare the target information CRO3 versus your new test formulation, and then estimate it. The percentage prediction error is only less than 5%. That means you can confidently request for the biowaiver for this product. That's all I have to share on this IVIVC toolkit. Now I will hand over this to my colleague, Andre Keller, for Q&A session. Thank you for your attention.
Thanks, Lori. Right now, we are going to go to the Q&A portion. Feel free to submit a question on the panel on the right-hand side. Right now, we'll take a couple questions. Can we use IVIVC toolkit for nonlinear correlations?
Yes, you could use it. So we have an option. Let me go back. I'm not sure whether I can go back. So there is an option where you can write your own equation. It can be done. Yeah, you can write your own custom model.
Okay. Should we include target or innovator product data for external validation?
No, ideally, the target, if you are referring to target as a innovator product, definitely not, because that's not coming from your own technology. Most often, you may not know the technology behind the innovator product. But if you have conducted an additional biostudy with your own technology, and you could use that data.
Okay, sounds good. Well, because of the time commitment, we're going to kind of run it up close to the top of the hour. We're going to stop right there. I just want to remind the audience that Certara offers introductory, intermediate, and advanced courses for Phoenix products. Some of the new courses that were added, and here's a sample listing, is just for our next IVIVC toolkit for Phoenix Win Online. It's going to be happening, the training is going to be happening April 21st and the 22nd of this year in Düsseldorf, Germany. And I just wanted to remind the audience that a link to the replay of this webinar, along with a slide deck, will be available on the Certara website within the next couple of days, and I'm going to be sending a follow-up email out to all of the registrants and attendees. The current slide provides information on whom you may contact with any questions you have regarding Certara's products and services in the Americas, Europe, India, and Japan. On behalf of Certara, I'd like to thank everyone for attending today's presentation. This concludes today's webinar, and everyone may now disconnect.